Okay.
Okay, so we're having trouble having Joan call in. So we're going to go ahead and stick her on speaker. And Joan, I just want to do a sound check really quick, and we'll get some feedback from the audience to see if they're able to hear you. So Joan, could you go ahead and speak up?
Hi, this is Joan Parker.
Hi, Joan. Folks on the line, are you able to hear Joan? Okay, perfect. So we'll go ahead and, Joan, we'll go ahead and advance your slides for you. You just can go ahead and get started.
All right. Well, thanks, first of all, to Lori and Kathy for doing their part, and I appreciate the opportunity to share my story here. As you see right now, the picture of our hospital is up on the screen. And this is Gothenburg Hospital. We're very far northeast corner of Iowa. We have a small rural hospital, less than 25 beds. We border on the state lines of Wisconsin, Illinois, so we have a lot of people traveling from interstate. I just wanted to plug that Cornerstone Family Practice, Gothenburg Municipal Hospital and Clinic, became a patient-centered medical home level 3 this past fall. So obviously we're doing something right. So the first picture shows us who we are. So if you go to the next slide, please. I want to share a little bit of a history about how we got started in connecting and collaborating our care. So in 2002, a readmissions PIP team came together to discuss ways on how we can help reduce those readmissions, whether it be an all-cause or for the same readmission. As we know, Medicare comes in and they say they're going to start to deny or reduce payments for those readmissions of same diagnoses. And so this really prompted us to look at what we need to do in order to not be denied payments, but how we can help our patients as well. Next slide. So the team that was brought together are listed there. We had a quality person. This was a nurse from the inpatient care unit, and she actually played a large role in quality. I played the clinic nurse. We had a pharmacist. We had care centers, visiting nurses, and also the assisted living center. So all of us came together at one table to really start having a discussion about what does this look like for everybody across the spectrum of, in our neighborhood, of who we take care of on a day-to-day basis. Next slide, please. So we formed an aim statement from the team. So as you see, by March 31st, 2013, we were going to decrease the same diagnosis readmissions to less than 3%. We were going to decrease our all-cause readmissions to less than 10% for all inpatients through implementation of these best practices. The best practices were put together by a team of us, along with some physician input, to determine that we were providing the best care for our patients in order to avoid disease readmissions and into the hospital environment. Next slide, please. So in 2002 readmissions, you see in that current fiscal year, the overall same diagnosis readmissions was 1%. And as you see, the Medicare congestive heart failure, pneumonia readmissions were very high at 23 and 19%, which of course exceeds the U.S. top 10% of hospitals. So obviously there was a lot of work that needed to be done. And our all-cause readmission rates were also elevated. We know that some of the readmissions came from our care centers, and of course they take care of our elderly patients for the most part, and we feel like that's why they were brought to the table to really help us to dive into how can we prevent this and what cares can we give them. Next slide, please. Here is some data that we had collected throughout this. In 2013, you can see by the same diagnosis or all-cause rate, our percentages. But as the years went on, you can see that in 2015, we had a 0% sustained diagnosis. Our all-cause rate has really decreased. And then a little bit up, a little bit in 16, but that always makes us look at what more can we do. So just a good slide for data. Next slide, please. You know that across the spectrum of healthcare, whether it be inpatient, outpatient, nursing homes, visiting nurses, all the collaboration that needs to happen, you need strong engagement. And this isn't only from the staff that takes care of the patient, but it's also from the patient itself. One of the most critical aspects that will determine success is to have this engagement from all sides. And so that's just really what's going to determine whether or not this is going to be successful or not. Next slide, please. So currently our team consists of a social worker or care coordinator or care navigator, is whatever term you're coining, a health coach from the outpatient or clinical setting, the provider, the patient, and the health information department. These people in a collaborative team really work to help this patient determine what can keep them the healthiest and how can we provide that care. Next slide, please. We're going to dive a little bit into the process of how this happens. The social worker or whoever you have on the inpatient side reviews the patients as they're admitted to the patient care unit about really what brought them to the hospital and why are they in the hospital as an inpatient currently today. When it involves a chronic condition, a health coach brochure is given to that patient. It really explains our services. So there's just a small little snippet shot of what our healthcare pamphlet looks like. This is something I've created, and we use this internally and across the neighborhood or spectrum of our healthcare. We're really trying to put the word of health coaches out there and what we can do to help our patients in collaboration with them. Next slide, please. If that patient agrees to having a health coach session or somebody to talk to about their chronic condition, the provider will put their referral in, and then the social worker from the inpatient care side will contact the clinic and give us that information while the patient's in the hospital. That is the best time to at least start having those conversations, that we catch them. You don't want to say at their weakest point, but a point that maybe they determine that I need some help to stay out of the hospital. Next slide, please. During the hospital admission, each patient with a chronic condition, or if that's what led them back into the hospital, is given a folder of information. The folder contains information about their chronic disease. Most people understand that they might have congestive heart failure, they might have hypertension, but truly, what does that mean? So we need to give them the information that's either a contributing factor to their inpatient hospitalization now, or it could be a comorbidity, so we need to define which one is the one that's giving them the most difficulty. And so a health coach will then arrange a time to meet the patient in the hospital. And of course, this is where your conversations start to happen to engage that patient into their health care and to understand their disease process. Next slide, please. The folders that are given to the patient are given in the form of education. They're in zones for that chronic condition specifically. The zones were made as a standardized tool for use across all disciplinary areas of teaching, so that we know we're all teaching the same thing. We all talk the same talk, and the patient hears the same stuff repeatedly. It reinforces then hopefully some education to them. It also reinforces their engagement into their own health care. There are 4 folders that we have developed in 2013, and you can see those are some of the main or the most chronic conditions that people encounter with today. Next slide, please. So our folders are color-coded, or the zone areas are color-coded. The very top part of the zone is a gray color. And that gray color identifies what that person should be doing every day to keep them healthy and out of the ER and hospital. So if it is a person with congestive heart failure, they should be weighing themselves every day. They should be following maybe a certain diet. A diabetic should be doing their glucose check. They should be following a low-carb diet, doing some exercising, and taking their medications every day. The green section of the zone says when they're feeling their best, this is what it looks like. The symptoms are under control. They're not having any low blood sugar feelings, shakiness. They're not having high blood sugar readings. They're not short of breath. They're not having chest discomfort. All the symptoms that would maybe lead them into the hospital or ER. Next folder, next slide, please. The third section is a yellow zone. It identifies when the symptoms are changing or a new symptom is presenting itself. This is the zone that we like patients to say, this is when I need to call the doctor to get further instructions or direction. So that person who has CHF and they all of a sudden have a 5-pound weight gain or shortness of breath, they should be calling the clinic and asking their physician, I need some help. This is where I'm at. Or the diabetic who has a blood sugar of 500 and they took their medication, so what's changed? Then the red zone is when that patient's at their absolute worst. They're going to call 911. They're going to go to the emergency room. More than likely, they'll be hospitalized. So what part of their disease process that needs some intervention, or did something else happen? This is the zone that we're trying to avoid. This is part of that readmissions process. The slide that you see is a document. This is a sample of one of our zones, and it's our blood pressure zone. So you can see it's very color-coded. It's very bright. We give this in lamination. We tell patients to put this on their refrigerator as a reference for them every day, knowing that when they come back into the clinic, we're going to say, or on the phone call, what zone are you feeling you're in today? Are you having some of those symptoms? And then we can give them the advice that they need. Next slide, please. So initially, we have to talk to our patients. One of the first things that you really have to learn is, as Kathy and Lori alluded to, is that not only do you have to be a good conversationalist, but also a good listener. Because you really need to meet that patient where they're at today. If I push a lot of information on them and they're not ready to receive it, more than likely they will not be receptive or engaged in their healthcare to make improvements and to make some behavior lifestyle changes. So begin those conversations while in the inpatient side with the health coach. We then follow them through the clinic, ensuring that that face-to-face and another face-to-face is encountered, and that we continue to talk the same talk. It is determined with that patient, maybe do they want to continue to have sessions? Most of those are done by phone after that initial post-hospital discharge in the office. We can do some face-to-face. Some of our patients come in routinely, so that's the initial talk between the health coach and that patient. Next slide, please. So across the continuum of care, it is important to understand that you're not a silo. You have those other resources to make this happen. Of course, as I said, the patient is your best resource. They give you the most information on how they're feeling. We currently are putting some other processes in place. We are following some of our emergency room patients to determine that a health coach is needed. Are they using the ER as their avenue of care? Do we need to establish them as a primary care provider? And are they using that emergency room for emergency type symptoms only? units for the skilled level of care. Being a rural health hospital and clinic, we would like to have those post-procedure following back at our hospital to do outpatient therapy, rehab, and a skilled level of care. We're also looking at developing care transition teams with the health coaches, the hospital care coordinators, and social workers as being members. And our future plans are for the expansion of health coaches resources to really collaborate even more with our visiting nurses and care centers. We believe that these are nurses and staff that are going out and seeing our patients face to face, day to day, and that they could be a real good resource to us in giving information. Currently, we have 3 health coaches on staff. I am one of those, although I don't actively health coach as much as I did initially. I oversee the 2 other health coaches in the clinic, and I can tell you every day they do not lack for anything to do, as we know that our patients really have formed a great bond with our health coaches and our patient care unit and our resources outside of here. And as you can see, we're continuing to develop more and more as we know that the Medicare and the way the physicians are going to get paid in the future are on quality, so we're helping patients to get on board. So I'm going to end this. If anybody has any questions, I really apologize for the audio today, and hopefully this wasn't too much of a hassle for anybody, but I appreciate the opportunity to share our story today. And next slide, I think, just states if there's any questions out there, I would be happy to address any of those.
All right, thank you very much, Joan. I appreciate your flexibility, and thank you, everybody that is on the line, for sticking with us through these technical issues. We apologize. So we are going to move on to our last presentation of the day, Dr. Dawn Klitgard. And hold on one second here, Dawn, I will get you. All right, Dawn, can we go ahead and try a sound check? Are you on?
Hello, can you hear me?
All right, yep, you are there.
Perfect.
All right, so Don Klitgard is one of our faculty physicians. He's been passionately devoted to the creation and growth of Heartland Rural Physician Alliance, a statewide IPA dedicated to helping independent practices in Iowa thrive in the rapidly changing world of value-based purchasing and healthcare delivery transformation. He currently serves as the board president and ACO medical director for both Medicare Shared Savings and Wellmark Blue Cross Blue Shield ACOs. In 2014, Dr. Klitgard transitioned from 16 years of full-scope rural clinical practice to a new role as vice president and chief medical officer of Accountable Care Associates of Springfield, Massachusetts. In addition to serving as the national medical director for healthcare, work with ACCS and PACS. In 2015, he created MedLink Advantage, a healthcare consulting and ACO management company that he leads as CEO. He is also an active member of the AASP's Commission on Quality and Practice. Dr. Klitgard graduated from the University of Iowa College of Medicine and completed his residency at the Lincoln Family Medicine Program in Lincoln, Nebraska. So welcome, Dr. Klitgard. I'm just going to pull up your presentation here.
Perfect.
And I can go ahead and run your slides if you're all right with that.
That's fine with me.
All right, so I will hand it on over to you.
All right.